Hello, this is day back at work, day back of surgery after American College Foot and Ankle Surgeons meeting in Las Vegas, Nevada, 2017, or 75 years of American College Foot and Ankle Surgeons. You know, it came as a surprise to me that actually a lot of students and podiatric residents view my videos. The videos are intended initially for patient education, but I see that podiatric students, podiatric medical residents, as well as other residents and physicians look at my videos. So um, that's very humbling. And I would like to give something back to you guys as far as a topic that sometimes is hard to understand and to know what to do. This would be talking about osteochondral lesions as well as osteochondral fractures of the talar dome. This is something that can be confusing as a student or resident or even a practicing physician. Sometimes you get confused about what there is available, as well as patients too. So let's talk about that osteochondral lesion or defects. Now, I will say this is a good example of this is a Zimmer foot model. You see that little, this is a cancellous bone inside the talar dome. This is the talus, as you can see. This is the cancellous bone. This little white thing right here is a bone graft, the calcium phosphate from Zimmer, the subchondroplasty. So first question is, why is it there? Now, sometimes when you guys look at an MRI, a frontal plane, where it cuts the foot up like this in this plane, you'll see some swelling inside the talus. That's called more of a subchondral fracture or swelling within the talus. Patients will typically come in and complain about, hey, after my ankle injury 6 months ago, I just never fully recovered. I sometimes hear I would feel or hear clicking in my ankle, as well as I continue to have pain there, and it's not resolved via anything anti-inflammatories, injection by another physician, or physical therapy. So an MRI shows us that swelling, and a lot of time when you see the swelling on MRI, this will be basically when we go in there, it's filled with fluid. Swelling inflammation is fluid. So in the, I would say, in the environment of this cancellous bone or spongy bone or bone marrow, as layman's terms, you'll have a little swelling or fluid around this area that you'll see on an MRI. So basically, what we do, this is a tail. So as we know, we have two most common types. We have the anterior medial or posterior lateral. Of course, there's also the anterior medial, anterior medial or posterior lateral. Sometimes we get them centrally. So the MRIs can be a good guide. Now, how do we get this? How do we get this fixed? Well, if the cartilage on top is good, there's no need to invade the cartilage. So right now, Zimmer has a good subchondroplasty where you go ahead. Let's say the lesion's up here on the anterior medial. Let's go anterior medial right here. So there's an option to go here, go in and shoot back this way to shoot at the lesion. But over here on the medial side, you have a lot of vital structures, as well as the medial malleolus that we don't see here, or the big bone of the ankle. So go at this notch, we shoot at an angle, find it under in operating room fluoroscopy, and then shoot this graft into there. Same thing for this side, posterior lateral. We can go underneath the talar neck, come in underneath the talar neck right here, go in and shoot right back over here, posterior lateral, anterior medial. So wherever it is, do this plan this percutaneously, and we'll be able to get this nice fill. It's going to go into the area of least resistance. Typically takes about anywhere from 1 to 3 cc's to fill this area of lesion. Now what happens if we have a lesion on the cartilage itself, the osteochondral lesion? So you have a simple one where it's just a depressed cartilage. More complex, you'll have detached cartilage, and sometimes you have detached cartilage with a fractured bone. So there's many different kinds. We have a classification out there called a Bernhardi classification. So for those academics and for your boards, study that. But depending on how big it is now typically back in the old days, what we used to do for those is go ahead and drill out the osteochondral defect, or I tell my patients it's a pothole. Basically, if I look at this, it goes all the way up. It would go all the way up to here. It'll involve the cartilage, so it's a pothole. So in the old days, what we used to do is just take a big plug out of here and get a graft out of either have our orthopedic colleagues take it out of the knee, or we go ahead and some doctors take it out of the medial aspect of the navicular right here, the cartilage and the navicular right about here. Since this is a non-articulating area for most patients, so go ahead and take a small plug out of here and put it back into here. Now, a newer technology that we have available nowadays that works really well is the de novo, also from Zimmer. The de novo. What is de novo? De novo is just an articular graft that you'll have. Is a juvenile cartilage. It's a juvenile cartilage graft. Basically, it mimics the cartilage on top, so it's like a putty. You mix it with fiber and glue, and let's say you create this little divot. You take away the articular cartilage, the bad articular cartilage, you lift it off, and you fill in this hole, this divot, like a putty. This juvenile articular cartilage and fiber mixture, you put it in there. Now, at AFAD, they talk about doing it arthroscopically. I tend to like to do it open, just because I can see the whole lesion and make sure that all the articular cartilage, the damaged articular cartilage, is taken out. Again, that's surgeon preference. So that is that. The lesions I've been dealing with the de novo tend to be about 15 millimeters to 20, 25 millimeters. So they're pretty big to address arthroscopically. We tend to get the worst of the worst down here. So that's in summary, osteochondral defect and injury to the talar dome, as well as the subchondral bone for the talus. Now, for you residents and students, keep studying hard. I will say read McGlamory has improved significantly. Also, when I was a lot of questions I get are what did you study for what did you use to study for the boards? I would say study the back in the day we had the University of Pennsylvania manual or the Temple manual. If you're studying for the boards, I would say study the Boards by Numbers is a online or disc program that will guide you and test you along the way to see where your weakness may be when you pass the board. I can't overemphasize how important it is to pass your boards. The American Board of Foot and Ankle Surgery. A lot of hospitals require it nowadays, and your employer will appreciate that too. So, any question, please feel free to contact me. And thank you for subscribing and viewing my videos. Pass this along. This is directly talking to you, our podiatric residents and students. Any topic that you need me to clarify clinically or show you more clinical cases, I'd be glad to do it. We do have a lot of pathology here, as well as our own fellowship at www.fflcreconfellowship.com in Naples, Florida. We take one a year post-residency. So thank you for your attention.